A 43-year-old woman presents to the neurology clinic with significant pain. She reports a sharp stabbing electric-like pain on the right side of her face. The pain started suddenly 2 weeks ago. She reports that the pain is so excruciating that she can no longer laugh, speak, or eat her meals, as these activities cause episodes of pain. She had to miss work last week because of this. Her pain attacks last about 3 minutes and resolve when she goes to sleep. Currently, she typically has 2 to 3 attacks per day. Her blood pressure is 132/84 of a millimeter Hg, heart rate is 79 per minute, and respiratory rate is 14 per minute. A neurological examination shows no loss of crude touch, tactile touch, or pain sensation on the left side of the face. The pupillary light and accommodation reflexes are normal. No drooping of her mouth, ptosis, or anhidrosis is noted. Which of the following is the most likely diagnosis in this patient? Explanation. Correct answer C. This patient presents with typical findings of trigeminal neuralgia. Trigeminal neuralgia is debilitating to patients because it begins as a sudden, shock-like or throbbing pain in the regions innervated by the trigeminal nerve branches V1 ophthalmic, V2 maxillary, and V3 mandibular in the face. Trigeminal neuralgia more commonly affects women and is usually idiopathic. In some cases, trigeminal neuralgia can result from the compression of the trigeminal nerve by the nearby superior cerebellar artery (SCA) as it exits from the pons in the brainstem. Other causes of trigeminal neuralgia include viral infections, multiple sclerosis, and tumors such as cerebellopontine angle tumors. The pathophysiology of trigeminal neuralgia is associated with the compression of the trigeminal nerve, which can lead to focal demyelination and subsequent hyperstimulation and excitability of the nerve fibers, leading to episodes of severe pain. Trigeminal neuralgia is usually unilateral, particularly in idiopathic cases, such as in this patient. The first-line treatment for trigeminal neuralgia includes carbamazepine or oxcarbazepine therapy. Narcotics are not usually recommended as they provide minimal benefit and carry a risk of dependence. If medical treatment is ineffective, surgical approaches, such as SCA scaffold surgery, can be considered with the goal of decompressing the trigeminal nerve. Image: innervation of the face by the branches of the trigeminal nerve. By Lechurio. Option: Bell's palsy results from facial nerve damage. This affects the facial muscles innervated by the facial nerve and typically leads to drooping of the mouth and the inability to close the affected eye. These features are not present in this patient. Option B. Cluster headaches are a type of primary headaches which is associated with autonomic findings, such as facial flushing and sweating. None of these features is present in this case. Additionally, cluster headaches usually affect men, start during sleep, and typically present as pain around the eyes. Option D. Trigeminal cephalalgias are also associated with intense pain that can be episodic or chronic. However, they are associated with autonomic findings such as sweating, agitation, and allergy-like symptoms due to the release of histamine. Option E. Migraines usually present unilaterally with throbbing pain but are typically associated with nausea and vomiting. A basilar migraine is associated with vertigo, a perception of movement, and may lead to loss of consciousness. This patient's pain is more consistent with trigeminal neuralgia. Learning objective: trigeminal neuralgia is a debilitating condition that presents with excruciating, sudden, shock-like or throbbing episodes of pain. The pain may be localized to the regions of the face innervated by the trigeminal nerve branches. A 21-year-old woman is brought by her brother to the clinic for evaluation. The patient's brother says that 3 days ago, the patient had put on her best pantsuit and some makeup and insisted that she was returning to work and driving to Seattle to replace the CEO of Amazon Corporation. He says this was especially odd because her husband had recently died in an automobile accident in a different city 2 days previously. Today, the patient's brother says she is sad and is wearing gray jogging pants. The patient says she does not recall acting odd and she remembers that her husband is dead. Her blood pressure is 132/84 of a millimeter Hg, pulse is 92 per minute, respiratory rate is 16 per minute, and temperature is 37.4 degrees Celsius, 99.4 degrees Fahrenheit. Upon physical examination, the patient is observed to have a sad affect but her speech rate and volume are normal. There are no hallucinations, mania, interruptive speech, depressive symptoms, or loss of interest in the activities she once enjoyed. The results of a urine drug screen are provided below. Amphetamine negative. Benzodiazepine negative. Cocaine negative. GHB negative. Ketamine negative. LSD negative. Marijuana negative. Opioids negative. PCP negative. Which of the following best describes the patient's state? A 21-year-old woman is brought by her brother to the clinic for evaluation. Upon physical examination, the patient is observed benzodiazepine negative, marijuana negative. Correct answer E. This explanation. Correct answer E. This patient most likely has brief psychotic disorder. A diagnosis of brief psychotic disorder requires the presence of psychotic symptoms for at least 1 day but for less than 1 month. Mood disorders such as the mania of bipolar disorder must be ruled out. The use of recreational drugs must also be ruled out. Risk factors for brief psychotic disorder include female gender and living in an underdeveloped country. The most effective treatment of brief psychotic disorder is with an antipsychotic, e.g., risperidone. If agitation is present, a benzodiazepine, e.g., lorazepam, may be given. Option: schizoaffective disorder meets the diagnostic criteria for schizophrenia and a major mood disorder, e.g., bipolar disorder and major depressive disorder. To fully satisfy the criteria for a schizoaffective disorder diagnosis, a history of at least a 2-week period of psychotic symptoms, hallucinations and/or delusions without a prominent mood episode must be present. Option B. Schizoid personality disorder typically presents during the early stages of adulthood and the diagnosis is made based on the presence of at least 4 of the following characteristics: does not enjoy close relationships, prefers solitary activities, little interest in sexual activities with another person, takes pleasure in few activities, lacks close friends or confidants, appears indifferent to the praise or criticism of others, and show emotional coldness, detachment, or flattened activity. The characteristics mentioned above must be noted in the absence of schizophrenia, mood disorders with psychosis, another psychotic disorder, or autism spectrum disorder. The recommended treatment is regular psychotherapy, with antipsychotic medication as a second-line alternative. Option C. The diagnosis of borderline personality disorder requires 5 or more of the following: aversion to real or imagined abandonment, unstable relationships that transition between extremes of idealization and devaluation, negative self-image, self-damaging impulsivity, spending, sex, substance abuse, reckless driving, and binge eating, recurrent suicidal threats or behaviors, affective instability, chronic feelings of emptiness, anger episodes or periods or irritability, and stress-related paranoia are dissociative symptoms. Treatment is with various psychotherapeutic methods, including dialectical behavioral therapy and mentalizing-based therapy, have been shown to be effective. There are no FDA-approved medications used for treatment at this time. Option D. Schizotypal personality disorder, a cluster of personality disorder, typically manifests earlier in life, childhood to adolescence, compared to schizophrenia and schizoid personality disorder, both present in adulthood, with a lifetime prevalence of 1 to 4%. Characteristics of the chronic psychiatric disorder comprise cognitive perceptual abnormalities, interpersonal problems, and odd behavior. Patients with schizotypal personality disorder have difficulty maintaining social relationships and behave in an eccentric manner. The recommended treatment is regular psychotherapy. Learning objective brief psychotic disorder is described as when an individual experiences hallucination, delusion, and disorganized speech or behavior between 1 day to 1 month, with the resolution of symptoms within the same frame of time. Risk factors for brief psychotic disorder include female gender and living in an underdeveloped country. The recommended treatment is with an antipsychotic medication, e.g., risperidone. A 63-year-old man presents to the emergency department after 3 days of difficulty breathing, orthopnea, and shortness of breath with effort. His past medical, surgical history is significant for a myocardial infarction 6 years ago and cholecystectomy 10 years ago. Medications include metoprolol, lisinopril, atorvastatin all daily, and furosemide as needed. Vital signs are temperature 36.4 degrees Celsius, 97.5 degrees Fahrenheit, heart rate 88 per minute, respiratory rate 20 per minute, and blood pressure 108/60ths of a millimeter Hg. On physical examination, there are fine rales in both lungs, his abdomen is non-distended and non-tense, and there is 2+ pitting edema from the ankles to the knees. Initial laboratory studies show Na 138 MEq, L K 4.0 MEq, L Cl 102 MEq, L serum creatinine, Cr 1.8 mg per deciliter. Blood urea nitrogen, BUN 52 mg per deciliter. What medication should be given first to treat this patient? A 63-year-old man presents to the emergency department after 3 days of what medication? Explanation. Explanation. What medication should be given first to treat this patient? Explanation. Correct answer A. This patient with a history of heart disease presents with fluid overload and acute kidney injury (AKI) and prerenal azotemia. As evidenced by the accumulation of nitrogen waste products in a bun, CR greater than 20:1. AKI in the presence of heart failure and fluid overload is considered a type of cardiorenal syndrome. In patients with cardiorenal syndrome, mortality and morbidity are significantly reduced when diuretic therapy is started early, and elevations in BUN and CR should not preclude the initiation of this therapy. Prerenal AKI is caused by hypoperfusion to the kidney and occurs with volume depletion due to hemorrhage, vomiting, diarrhea, low cardiac output, heart failure leading to cardiorenal syndrome, or splanchnic venous pooling and systemic vasodilation, cirrhosis leading to hepatorenal syndrome. Option B. Volume depletion is the most common cause of prerenal acute kidney injury (AKI). Treatment includes aggressive intravenous fluid administration. This treatment is contraindicated in cases of fluid overload with heart failure, as seen in cardiorenal syndrome. Option C. Hyperonchotic starch is a colloid fluid used to replenish intravascular volume in patients with volume depletion. It is not indicated in this patient with fluid overload. Risks include acute kidney injury (AKI) and bleeding. Option D. Terlipressin is an analog of arginine vasopressin with strong vasoconstrictive properties. It is used to treat hepatorenal syndrome. The goal of terlipressin is to reduce splanchnic vasodilation and improve hemodynamics. Option E. Norepinephrine is a strong vasoconstrictor used in cases of hemodynamic instability and profound hypotension seen in cases of septic shock and hepatorenal syndrome in the intensive care unit. Learning objective: prerenal AKI can be seen in patients with volume depletion, low cardiac output, or splanchnic venous pooling. In patients with cardiorenal syndrome, decreased renal function despite fluid overload, the initial therapy is diuretics for fluid overload.